So dear friends, welcome back to my channel. My name is Panagiotis Georgiou and I'm an ENT consultant based in Cyprus, trained in Germany. In this channel we deliver high-yield topics in ENT for a very concise and quick revision for you. So today we're tackling tuberculosis in ENT patients, and let's go see the information. Don't forget to like and subscribe if you like the channel. More videos are coming your way about ENT topics. Now, we're talking today about tuberculosis in ENT patients. What's the definition of tuberculosis? It's a chronic caseating granulomatous infection, mainly of the lungs, but also the whole body. Now, this is through Mycobacterium tuberculosis or other mucobacteria. The important point in the definition will be the caseating granulomatous infection, because sarcoidosis has a non-caseating granulomatous infections. So what do we mean by granulomatous? The granuloma is a tissue formation that's comprised of macrophages, epithelioid cells and Langerhans cells on the outside, and then on the inside, due to the apoptosis of the cells, then we see a cheese-like material in the macroscopic view. Now, epidemiologically, tuberculosis is seen more on migrating population, third world countries, and non-immunized population or immunodeficient population, with the most common incidence at 5 to 10 years old or 60 to 70 years old. The symptoms, the main symptoms of the patient that is coming to our praxis will not be the lung symptomatic, like coughing out blood, rather the cervical lymphadenitis. 20% of the patients that do have tuberculosis develop cervical lymphadenitis. This is also called scrofula, and they have a tendency to form fistulas on the skin and skin redness, as we see here in these pictures. Now, they tend to occur in the supraclavicular region or the nuchal region of the neck. Here we see a child that's having a lymph node manifestation with a fistula formation in the nuchal area, and here we see a young adult having the manifestation of the lymph nodes in the supraclavicular area. Of course, for the diagnosis, we need the diagnostic workup, as we talked before. Very important will be the anamnesis. We ask the patient if they went to vacation in high-risk countries or if they are migrants. We also ask the patients if they have any relatives with tuberculosis. Of course, we need to ask about immunodeficiencies like diabetes mellitus type 1 or 2. We need to ask about any corticosteroids that the patient is taking, or if the patient is diagnosed with HIV. Now, the second step will be a sonographic examination of the neck of the patient. Here we can sometimes see microcalcifications forming around the lymph nodes, and then very prominent cystic appearance of the lymph nodes, sometimes with central necrosis. Now, in the case that we suspect a TBC, a tuberculosis patient, we need to do a CT of the thorax. Here we can see the apical lesions, and also in conjunction with the pneumonologist, we can do a bronchoscopy with bronchial lavage and compare the CD4 plus CD8 ratio. If this ratio increases, then we're most likely having a tuberculosis infection. There are some tests, also blood tests or skin tests, that we can do, like the tuberculin skin test or the quantiferon test or the interferon gamma test, in order to have a positive reaction against tuberculosis. And then, of course, an ENT status. A very high-yield question that comes often in exams will be patient with fluorescence of voice come to your practice. He's a migrant and he has fluorescence for like a month now. You do an endoscopic examination and then you see this finding. One vocal cord is affected and the RE region on the same side is swollen. This is called monochondritis, and it's a very typical laryngeal manifestation of tuberculosis, also called tubercular laryngitis. It is usually found in the posterior part of the vocal cords, as we see here in the picture, with hyperemia, ulcerations, and like a mouse nibbled like appearance, like a mouse had chew on it, as you can see here in this picture. We also need to observe for an edema of the arytenoid cartilages in the area, as we see here. Now, if we're gonna test the lymph nodes surgically, we always need to use a fresh tissue sample. We send it not in formalin, but it's saline or without any fluids in the cartridge. And in the histopathology, what we expect to find, we expect to see the findings of the sonography with microcalcification appearance, cystic appearance, sometimes with central necrosis. Now, the therapy is of course tuberculostatica and isolations for many months. In Cyprus, we need to report these patients to the healthcare providers for registration. If there are any neck fistulas, then consider operating the patients and removing the lymph nodes completely. And if the lymph nodes are more than 2 centimeters in diameter, then consider also doing a growth biopsy. This comes with a risk of fistula formation. That's why nowadays is more likely, and the preferred method is to remove the lymph nodes completely. If you have a patient with lymph nodes that are centrally necrotic, always consider the following. 1 will be a toxoplasma infection. 2 will be a neck malformation, for example, thyroglossal duct or brachial cleft cyst. Very important, never forget an HPV head and neck tumor, so always check the oropharynx for signs of carcinoma, and then have in mind sarcoidosis, but this is non-cassating granulomas. That's all for today, folks. If you like the videos, like and subscribe to the channel. I'm very happy to answer your questions. Please write comments under the video. Thank you very much. See you next time.